The average human heart beats about 100,000 times a day. That's over 35 million times a year. About 600,000 people die of heart disease in the United States each year, 1 in every 4 deaths. And heart disease costs the United States almost $109 billion each year. Getting to the heart of the matter, the doctors are on call tonight. Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
LARSON Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Good evening and welcome to On Call Television. Among all of our internal organs, the heart carries an inordinate burden, not only emotional as the center of our passion for others, but also as the pump that moves vital nourishment and oxygen throughout our body. Minute to minute, hour by hour, day after day, it can never rest if we're to continue to live. In the 17th century England, with the support of the Royal College of Physicians, we can say William Harvey began the field of cardiology. Now cardiology internists provide for the examination and management of circulatory disorders of many types which occur in as yet unborn babies to the very elderly, including congenital heart leaks and valve abnormalities, clots and atherosclerosis, dilation and rupturing vessels, hypertension, chest pain, and on and on. In the 20th century, after scientists had discovered microscopes and bacteria and sterile technique, came surgery. And after nitrous oxide and ether gases were discovered to allow anesthesia, it came all together as Army surgeons in World War II began removing shrapnel from beating hearts. But how were they to operate inside the heart without causing bleeding to death? And the biggest challenge had to do with blood flow to the brain, which cannot be clamped any longer than 4 minutes without causing brain injury. Well, in 1956, the big solution came when in the University of Minnesota, an artificial heart and lung machine was developed so as to keep circulation to the brain and the rest of the body while giving time to work on the living human heart. Now they would go on to repair large holes, develop artificial valves, learn to bypass blocked arteries, and much more. Thus, the field of cardiac surgery came to fruition. Today we have a cardiologist and a cardiac surgeon to answer your questions. Dr. Jeremy Scott joined North Central Heart Institute in 2011, having done his medical school training at the University of South Dakota, Sanford School of Medicine in Sioux Falls, residency in internal medicine at the Mayo Graduate School of Medicine in Rochester, Minnesota, and his fellowship in cardiology and invasive cardiology at the University of Nebraska Medical Center in Omaha, Nebraska. Dr. Tommy Reynolds joined the North Central Heart Institute in a long time ago, 1992, after having done his medical school training, also at University of South Dakota School of Medicine in Sioux Falls, and his residency in general thoracic surgery at the University of Oklahoma Health Sciences Center in Oklahoma City. He's also certified in endovascular medicine. Gentlemen, thank you both for joining us.
Thank you.
So, Jeremy, tell me a little bit about what drew you into cardiology.
Well, I think there are several things. There are a lot of different areas in cardiology, and so there's some variety. I think also the medications work very, very well, whether it be for blood pressure or any number of other things that can ail the heart. And also there's a lot of technology there that certainly can draw in a young doctor, whether it be in the cath lab doing angioplasties and stents like I do, or any number of other procedures and things that really are fairly cutting edge in medicine.
And you were a Mayo Clinic trained internist, and
Correct.
then on to cardiology. Was something at the Mayo that really struck you? It was just that, as you described it.
You know, I thought about cardiology all the way along, and actually spent a month at the heart hospital with Dr. Carpenter, who I'm now lucky enough to work with. Yeah. And you know, I found it to be a fairly inspiring place, and was lucky enough then, and you know, decided that I wanted to do cardiology, and was lucky enough to be able to come back and work there.
Yeah. Are you originally from South Dakota?
I'm from the town of Alcester, so just south of Sioux Falls. That's right.
That's great. And Tom, you're related to Jim Reynolds. He's your much older uncle. Is that how it goes?
Barely older uncle. Yes,
Barely
older uncle. Yes, barely older. Yeah.
So, what drew you into cardiac surgery?
Well, I think unfortunately it was my uncle's choice to be a cardiac surgeon instead of an orthopod that got me into cardiac surgery. I wish he sometimes would have been an orthopedic surgeon, but he had made the choice to be a cardiac surgeon. So in my days in college, I rotated and went around with different physicians, and I thought his job was probably the neatest job.
It's a neat
followed
job.
in his footsteps. He's a wonderful man and
He
a
is
great
a wonderful
mentor.
man.
Yeah.
Yep, and a great mentor.
Yes, he was.
Well, we've got a number of questions and thoughts to get started. Let's talk about chest pain. Probably the basic issue. People will come up with classic chest pain. What is the classic picture of a person who's having a heart attack and the classic story of chest pain?
Well, I think the classic story of somebody who's actually having an active heart attack is certainly what they'll describe usually is a chest pressure or chest tightness that might be associated with shortness of breath, might be associated with some nausea, maybe even some lightheadedness or dizziness, and sometimes they'll talk about it going up into the neck or into the shoulder. Those are certainly the most classic symptoms, I think.
And they'll sometimes sweat with this.
Correct.
And the feeling of doom, as they always say. Something's bad happening. Yeah, I think that's the classic picture. How often is the classic picture what we see?
Well, I think we don't always see the classic picture with all of those things, certainly. I think most of the time we see at least part of that picture. Occasionally we see somebody who comes in who's just gotten very short of breath or very sweaty or diaphoretic, but usually there's some sort of chest pain that goes along with that. We just may not see all of those things that we just talked about.
How about women?
You know, women and sometimes I think diabetics as well maybe don't get quite as classic a picture, and I think they're the ones who are maybe more likely to come in complaining more of the other things that we talked about, like shortness of breath, or the profuse sweating and things like that, and chest pain may not be quite as prominent a symptom for them.
I have a 95-year-old person I saw today whose EKG shows big dead zone in the anterior part of her heart. No EKG changes otherwise. I mean, the ST and the T wave are perfectly normal. In other words, it's an old anterior big-time heart attack, and she has no history of it. How often do we see people who've had heart attacks? EKG shows you've had a heart attack, but there isn't any symptoms or history.
I see that fairly often, to be honest, and you know, it's hard to know. It may be that episode of chest discomfort that somebody thought was heartburn that they chalked up to heartburn or something else, that maybe was in fact a heart attack. Maybe they had the heart attack in their sleep and didn't wake up. But we don't see that all that infrequently, that someone has an area that shows evidence of a heart attack and we have no idea when that happened.
And we're going to talk about bypass surgery for heart disease in a minute, but let's talk about, okay, somebody comes in with a chest pain, heart attack, sweating, just started 15, 20 minutes ago, or maybe had a cardiac arrest and was resuscitated and brought to the emergency room in Brookings, South Dakota. There's an issue of time, is there not? Let's talk about an acute heart attack and the time issue.
Well, the time issue is a huge one, and what we typically say in the cath lab is that time is muscle. And so if someone walks into the cath lab in Brookings, what will typically happen is that they get an EKG right away. If that shows that there's an artery that's completely blocked or an ST elevation MI, then what usually will happen is that I'll get a call from the ER doc, whether it be in Brookings or another town. And unless I'm pretty confident that I can get them to Sioux Falls and get them into the cath lab to get the artery opened up, I'll typically actually suggest to the doc on the other end of the line that we go ahead and give a clot busting medication to get the artery opened back up. That's a little bit different than somebody who comes into one of the ERs in Sioux Falls, in which case if I see those changes on the EKG, I'll take them to the catheterization laboratory, take pictures of the arteries, and try to get it opened back up with a balloon and a stent.
So, and that is an acute event. I mean, that is in a time where you can reverse the process of heart muscle being destroyed. And if you could do it in less than...
Well, you know, the guidelines from the major societies will say to try and get it in less than 90 minutes. Certainly out to 3 to 6 hours, there's still going to be some recovery of heart muscle likely. If it gets out longer than that, then it's probably too late to do anything about it.
Acutely.
Acutely.
Right. And so the real importance of that stent, that angioplasty, finding the clot, opening up, probably the most important part is that first bit.
Correct.
Now, so you're in the Brookings Hospital, you have pain, I've called you, they came in 15 minutes. To get to Sioux Falls is going to be another hour. I don't care how fast I do, whether I do helicopter or ground ambulance, it doesn't matter, it should be an hour. It's just not enough to get them in that first 90 minutes probably.
Sure. You know, in those cases and for most cases outside of Sioux Falls, what I will recommend is giving the clot busting medications and then, you know, putting them on a helicopter or an ambulance, whichever is going to be the fastest to get them to Sioux Falls. And if their pain isn't under control and they still have changes on their EKG when they get to Sioux Falls, then we go to the cath lab. If all of those things have resolved and the clot busting medication has done its job, then we'll wait a day or two and probably still go to the cath lab just to make sure they don't have something that's just letting a little trickle of blood through. Right.
So the majority is that's where the stents really come in. But what really makes a difference for a stable angina that's kind of coming up is the bypass surgery. Let's talk about bypass surgery. Better than angioplasty. When is that scenario, Tom?
I think the ones that probably show the most benefit from bypass versus multi-stents are those diabetics with disease in all three of their vessels. Also see people that have disease in the left main coronary artery, which is, I'll show off this heart if you want to show the heart off, Rick.
Yeah.
If the left main coronary artery, the left side has two arteries, the left one comes off right off the main, off the aorta, it divides into the main artery down the front, which used to be called the widowmaker, and the one around the side. And if that one's blocked, you basically lose two arteries at once, and so bypass surgery has probably been shown to be more effective than stenting in that situation. So.
Right, and actually what we're really talking about might be the vessel that's sneaking up on you, and it's a diabetic patient in particular, not this acute event.
Correct.
It's that acute event, the angioplasty and the stents. It's the chest pain that's coming up, something's wrong, you do the treadmill, you can see there's problems.
Right.
Then it's more often the bypass surgery.
They've had an elective cardiac cath most of the time. You know, in the early days, when they were just starting angioplasty, we tried to do emergency bypass surgery, but right now, I think the evidence suggests that with the acute event, straight to the cath lab and open that artery as quick as you can. And some of those people that have multivessel disease may benefit from bypass down the line.
Right.
And if it's the chronic situation, if it's all three vessels or certainly the left main, like Tommy was talking about, certainly the bypass is still probably the best option. If it's only one vessel that's giving them pain, then probably the stents are going to be the better way to go. With the understanding that if the disease does progress further down the road, a bypass still might be an option down the road.
Okay. Well, about 1 year ago, Tom Bozied of Brookings had a severe heart attack. With the fast work of the emergency room doctors and the staff, he survived. He had a full cardiac arrest. Well, we checked in with Tom recently to see how he is doing and what he is doing to help prevent another heart attack.
It was about December 23rd of last year.
Oh, so we're right at a year.
Right at a year.
So how are you feeling?
I actually feel better than I did before. Every time I went in, told me that it would be nice if I'd lose a few pounds and get out and exercise. And this was probably the only thing that stimulus to get me to get out and exercise. And so I finally decided that I better pick it up and do it. And so I think I feel a lot better because of exercise. And I try to eat more in a more healthy fashion. I've got some recommendations I don't always follow because my doctor told me moderation and everything. Part of it, both my knees I've had surgery on, and the last 4 or 5 years, I've had not substantial but nagging pain in my knees, and since I began exercising, it's almost gone away. Well, my cardiologist said that if you exercise and open your veins up, there'll be less chance of the blockages that do develop, and you'll just be healthier. Your cardiovascular system will be just a more healthy situation. I exercise 3 to 5 days a week. I try to get up at 5 when the wellness center opens. There's not as many people there, and I can get done and go to work and still be to work early. The hardest part is probably the cardio, where you need to get your heart rate up. It's kind of boring, and I'm just glad when I get through that. And I also do the machines for weights and then flexibility. And the best part is when I'm done. I think if I don't exercise, it's more of a mental problem for me than it is physically, because even if you miss 2 days, which I do sometimes, it takes more than that. But mentally, it's tough. Well, I think I feel that I'm at less risk, as I exercise regularly and, try to manage my weight, and I feel better. Yes.
A nice little nurse at the heart hospital. So that's special.
Oh, I'm just learning about Jeremy's going to get married pretty soon. Well, congratulations on that.
Thank you.
There you go. That's really neat. Nurses.
Found
I don't know. Marrying nurses. I don't know. Is your wife a nurse?
Ex-nurse, yeah.
Yes.
Yeah.
My wife is also. So that's good. I highly recommend it. Right. Well, we're talking about bypass surgery and coronary angioplasty and stents and so on and so forth for coronary disease. How much of what you do every day is coronary disease? I mean, that's the arteries that feed the heart, right? The arteries that come off, let's see if I can make this work. The arteries that come off the aorta, and they come around the different parts of the heart and feed the heart itself.
Sure.
How much is coronary disease that you do?
Well, I would say in my average day, probably half of what I do is chest pain, and probably half of that turns out to be coronary artery disease, with the other 50% being a mix of various different arrhythmias, some with just resistant hypertension and things like that, and some with heart failure, whether that be because of coronary artery disease that did damage in the past, or uncontrolled hypertension, or any number of other things. things, but probably half is chest pain, and about half of that turns out to be because of coronary disease.
How much of what you do is coronary disease?
Much less now. I mean, I think that just to give you some numbers, when we 1992, our group did 1,200 pump cases, or cases that involved the bypasses or valves. Were down somewhere in the under 500 range. So angioplasty, stenting has really changed that. Maybe medication, some changes may have changed that, but certainly there's much less bypass surgery done. And we've always been vascular surgeons as well, so we deal with the aorta, the carotids, and all the blood vessels that the heart pumps blood to.
Well, I think the numbers say that there's less coronary disease now. I mean, I think in the mid-2000s they talked about a 10% reduction in coronary disease. And then coming at the end of 2000, they say, well, it's starting to go up again because we think obesity and diabetes is a bigger issue. Do you go along with that?
I think there's probably some truth to that. I haven't been around quite long enough, probably, to remember some of the good old days where there was more. I think certainly reductions in smoking are going to decrease the amount of coronary disease, and I think that probably with all the obesity and diabetes that there are, that we'll probably see some of that come back as the population ages a bit.
Right. And before we go further, let's talk about prevention of heart disease. I mean, we can talk about prevention of heart failure, which we'll talk about in a minute, but let's also talk about prevention of coronary disease, atherosclerosis, hardening of the arteries that feed not only the heart of the arteries of the heart, the coronary arteries, but the arteries of the brain and the legs. What is it that what's the most important thing that a person could do to prevent this aging, this natural kind of aging process to occur?
Well, I think the most important thing people can do is to not smoke, and if they have smoked, to stop, because that certainly probably increases the risk as much as anything. And then the other things are to try and eat and exercise as well as we can, because diabetes is probably the second biggest risk factor for developing coronary disease. So I think if we don't smoke and take care of ourselves with diet and exercise, certainly those are the things that will prevent it.
Now, I've said in other times that that lipid-lowering drugs are one of those things that we can do to help take the risk down on certain patients, but that I think it's been overplayed. Now, I know that most of the cardiologists may argue with me, so I'm going to give you a chance to come back at it.
I would continue to argue that point, and I think certainly I'll continue to follow guidelines that are out there, which would suggest that for diabetics or smokers who we pretty well know have some coronary artery disease, whether it's manifest itself or not, that they need to have their bad cholesterol or the LDL be less than 100 and as close to 70 as possible. And for other folks, maybe they don't need to be on a statin drug, but they certainly need to do everything that they can to try and lower their numbers. But I think certainly cholesterol plays a big role in the formation of coronary disease.
I was at an ACP, Internal Medicine National meeting, when the editor of the Archives of Internal Medicine was updating all of the things on heart disease, and one statement she made was, we know that cholesterol is a risk factor for heart disease.
Sure.
And we know that if you've had a heart attack or you've got known heart disease, that lowering cholesterol will reduce your heart disease to some degree. But we haven't proven that lowering cholesterol in a person who's not had heart disease changes your risk factor. And the room went silent. And I know there's disagreement in that, but my sense is that it's a factor, but it's a much smaller factor than we've been led to believe, primarily by the $55 billion a year pharmaceutical industry argument.
Well, it's certainly a factor, and it's certainly not the only one. If you look at the current hypothesis for how coronary artery disease starts is that you probably have to have some area of inflammation in a vessel in order for cholesterol to enter the vessel. Now, there are a number of reasons why people have inflammation in their coronary arteries or in any other artery, and probably the biggest ones are smoking will cause inflammation in arteries, diabetes with blood sugars that are out of control will cause it, hypertension will cause it, and that's probably why we see more coronary disease, say at branch points in the vessel where there's more turbulence. And so, while cholesterol isn't the end-all be-all of it, certainly if you have less cholesterol floating around in the blood to stick to those spots that are inflamed, you've got less risk of developing plaques that are significant.
Tom, you have anything to add to that debate and discussion?
Oh, I think that the people that we bypass or do bypass surgery on, or do stents in legs or carotids or open surgery for those people probably should be on a statin. I don't think there's any question, because they've manifested signs that they have the disease. Yeah. So.
And it makes a difference, but it's not a huge difference. And my only comment is, like you said, Jeremy, I really think the people underestimate the value of exercise. There's so many people who are just not getting up off that couch enough. And I think, a walk a day could make a huge difference for somebody. I try to encourage 12 blocks a day, which is 1 mile. And there's some data that says it's huge. What about vitamin D? Do you have, either one of you have an opinion on vitamin D? Okay.
Not much of one.
Okay. I think it's something else and very good. 2,000 a day, and I like it.
Well, I mean, we at the North Central Heart Symposium a year or two ago, the professor came in and said if you live north of Kansas in the wintertime, you're not going to get enough vitamin D.
No, I don't care how you can't.
So you'll be benefit. So
2,000
I listened to him.
a day.
I said I'll try it.
It won't hurt you.
Told my wife to take it. Yeah, so.
Talk about heart failure a little bit. Certainly. Heart failure means it's not a heart attack, it's not coronary disease, it's a weak, dilated heart. We see a lot of that. Some of that just because they're so very old. Some of it's from long-term hypertension. Some of it's from alcohol. Some of it's from previous heart attacks or valve disease. Mm-hmm. How often do you see it, and what do you feel about the options of therapy that we have?
Well, it's certainly a major problem at this point, and for some of those causes of it, there obviously isn't a lot you can do once the damage has been done. If it's been long-standing hypertension, or if someone's already had heart attacks that have damaged large parts of the heart muscle, certainly there are data out there that certain medications may help improve heart function a little bit, and in some cases, the only thing really left to do is to give people some water pills to keep their kidneys from holding on to too much fluid. Yeah. But really, the trick, I think, with heart failure is to try and take care of the things that caused it before the damage was done.
Once the damage is there, it's tough. I had a gentleman just pass away from heart failure, and it was just so hard to see him because he was progressively short of breath, and all of the what do they say, Humpty Dumpty, we couldn't get him back together. I mean, the cardiologist consults and every idea that we could think about it wouldn't work, and he slipped away. Great person. Let's talk again about other things. There is this issue of sudden death. It happens sometimes with athletes. These people die of an event unexpected. How can we as a society prevent that? A lot of people are talking, echoes on all of the athletes and so on and so forth. What do you think of that?
Well, the frequency of sudden cardiac death in athletes is actually rather low.
Really low.
But it's one of those things that makes the news every time it happens, and so I think it probably, while there are probably some things that can be done to prevent it, it probably gets more play than it really should. Okay. I'm not one who would advocate for screening echocardiograms. I think while an echocardiogram is certainly a benign test to someone, there's certainly costs that are associated with it. I think if their family physician hears a murmur or something like that, or they've had episodes where they've had a lot of problems with lightheadedness when they're exerting themselves, or chest pain and exertion in a young athlete, I think in those cases it's certainly something to go look for, because it could be a possibility that that's what's causing it. But other than just putting your stethoscope on a young athlete's chest, I don't think I'd recommend any particular screening beyond that.
Yeah, I'd add one other, and that would be a family history of sudden death.
Well, and that certainly would
stories.
also be a
right. Over 935,000 people suffer heart attacks in the United States each year, many happening without warning at home, work, or in the community. How can you help if you see someone collapse from something like a heart attack? If you were the one suffering, wouldn't you want somebody to help you? CPR is the best way to help.
The American Heart Association is the nation's leader in life-saving CPR training. In fact, we write the CPR guidelines for everyone, the public, doctors, nurses, and paramedics. This year, we've made a few changes so that it's much easier for anyone to save a life using CPR. Let's take a quick review of the new CPR process and when to use it. When someone's heart stops beating, it's called cardiac arrest. CPR is needed right away when this happens. Cardiac arrest victims will die if they don't get help fast. When cardiac arrest strikes, the victim typically collapses, stops breathing, or stops breathing normally and can't respond.
Sir.
If the victim does not respond, and the victim is not breathing or not breathing normally, yell for someone to call 911 and have them get an AED. An AED is a portable electronic device that helps the heart return to its normal rhythm. If you're alone, call 911 and get the AED yourself. Then follow the AED's voice prompts. If no AED is available, immediately start CPR, beginning with compressions. Doing CPR is not hard. Anyone can do it. And now the American Heart Association is making CPR easier than ever. We used to tell people that the proper steps for CPR are airway, breathing, compressions, or ABC. But we've changed that order, so the compressions come first. It's now compressions, airway, breathing, or CAB. This new order makes it easier because anybody can start out with compressions, even with no CPR training. Just push hard and fast on the center of the chest. If you haven't been trained, keep pushing until help arrives. When you give compressions, make sure you push the chest down at least 2 inches and allow a little time for the chest to come back up. Push as hard and fast as you can. The perfect rate for compressions is at least 100 per minute. That's the same speed as the beat of the song Stayin' Alive, so try to keep that tune in your head if it helps. If you've been trained in CPR, push on the chest 30 times, then open the airway by tilting the head back and lifting the chin. This helps air reach the lungs. Next, give 2 mouth-to-mouth breaths over 1 second for each breath, and watch for the chest to rise. Continue the CAB cycle until help or an AED arrives. Use the same CAB cycle for adults, children, and infants. This is just a quick overview. So to learn more or to sign up for CPR training that can help you save someone's life, visit our website at www.heart.org/CPR.
I wanted to come back to Tom Bozied because it was that very same thing we just watched there that brought him back to life and allowed us to defibrillate him and send him off to get an angioplasty and a life-saving procedure. You know, that's it. And I have to say also to thank Tom Bozied for coming on. It's a humbling thing to have to talk about your own illnesses, and so he's a courageous man, and we appreciated him. Let's talk about these sudden deaths things. When a person has an opportunity to have this cardiac arrest, what brings it on for the most part? I mean,
Well, certainly the most common thing that would bring on a cardiac arrest is probably a blocked heart artery and a heart attack that's in progress.
And it doesn't have to be a big one either. I mean, it could be a small artery.
That's correct. And for whatever reason, some people just get chest pain, and other people, that area in the bottom chamber of the heart that isn't getting enough blood will start this potentially fatal heart rhythm.
Now, there's an email, I think it's a misinformation that says that you can do self-CPR by coughing. What do you think of that?
Well, yeah, no, I would say not. While it is true that you can sometimes even in the catheterization laboratory, when we see a funny rhythm, we'll tell people to cough because it does increase the tone going through the nerves to the heart. But you have to know what's going on, and most of those people wouldn't be hooked up to an EKG machine at that point.
And they're going to be going, oh, I know what's going on because I'm passing out, and then they're gone.
Correct.
It's one of those email stories, but no truth to it.
Correct.
And I think that's what I agree with you. Tom, any opinion on that?
I agree.
A lot of pacemakers are being put in people, though, that's better than coughing. And defibrillator for people who have very slow rhythms. And then defibrillators for people who have fast rhythm abnormalities that cause them to pass out. Are you the one that puts in the defibrillator, or do you put in defibrillators?
In the early days, the cardiac surgeons put defibrillators in. We actually opened the chest, sewed patches on the heart, and put it in a device. Had to put it in the pelvis because it was so big. Yeah. And so it kept it in the surgery realm. As battery technology got better and better, and the leads got better, it basically transitioned to the electrophysiology physicians, and most of them are done by Dr. Mohama and Dr. Olson in our group. But now EP doctors do most of the defibrillator work.
So isn't that interesting? There's a whole field of cardiology that just devoted to rhythm. Mm-hmm. Any take-home messages about rhythm that we should make sure people understand? That the defibrillators put in young people who are at risk. Some people are saying they're putting them in people with heart failure. Jeremy, any comment? I mean, there's...
Yes. At this point, the studies have pretty well shown that if your ejection fraction, or the percentage of blood that's pumped out of the heart with each beat, which normally is about 55%, if it's down below 35%, then they're at a risk of something like 2% per year of having a fatal heart rhythm. And so at this point, if we can't get their heart function back up with medications or fixing their arteries with stents or bypass surgery, then at this point those folks are recommended to get a defibrillator implanted.
And I think that it's wonderful for a certain population, but then there's the time when how old are they and what their ejection fraction is, and when do you not put a defibrillator in it, because it is an invasive thing. And it's an expensive thing too. Certainly.
You know, I think that's a moving target and depends on the patient. You know, certainly if someone has some other illness that's going to be fatal in the next 1 or 2 years, then certainly that isn't someone that we would think about putting a defibrillator in. If they have, you know, a couple of years or more of life expectancy with all of their other health problems, then those are the folks that at least the experts who put them in would recommend at least considering it.
Yeah. What about a person who has, the old diagnosis was called idiopathic hypertrophic subaortic stenosis, IHSS. Now they call it obstructive cardiomyopathy of some kind. Explain that, and why is that important?
Well, what obstructive cardiomyopathy is it means that the heart muscle has gotten so thick that basically it gets in its own way. And so when those folks try to exercise, the blood pressure inside their heart chamber basically skyrockets on them. And there are some other abnormalities in the heart muscle, it's thought, that give them more risk for having one of these fatal arrhythmias. You know, certainly if those folks have a family history of hypertrophic cardiomyopathy and there's a family history of sudden cardiac death on top of it, certainly those are people who we would consider as candidates for a defibrillator.
Right. I've had at least one patient have a resection of that hypertrophic part of the heart. Have you ever done that procedure?
I've done it. It's pretty specialized, and most of the time those people are followed as a family unit, and a lot of times at other places. But you can resect part of the septum underneath the aortic valve, and that allows for better flow of blood out. Yeah.
But it's tough surgery.
It's a big operation, and you know but it can be very beneficial if you have that right anatomy.
All right. Let's talk about heart valve surgery. There is, I have a good friend who called me and he says, I know you're going to be doing a show on heart valve problems. I had, he said, a pulmonary stenosis case. Well, he's not only one of my friends who had pulmonary stenosis as a kid. I have another friend who had pulmonary stenosis as a kid, and both of these people were over in Minnesota in their growing age, at which time their pulmonary stenosis was treated surgically. And he said the major thing that he would like people to realize, and I thought this was very interesting, is he was stunted, his growth was stunted with congenital heart disease. Nobody talked to him about it. It was like the family didn't talk to him about it. The heart doctor was the one who really did. The family physician talked to his family. He was ashamed and felt guilty and it thought it was something to be ashamed of until he had the surgery, and he grew about a half a foot each year that he lived and became normal, could breathe and play and be active. And my comment is, you see that with people preoperatively, or is this a congenital heart kind of a...
I think it's more in that age group and the young people that are affected by that. I think most of us that are older, we've all known people that have had bypass surgery, or some of our friends have had stents already, and it's, you know, it's a kind of a way of life for us. If you have it, you have to deal with it. But certainly for that younger population, the congenital, that is an issue for them.
Yeah. Okay, let's talk about the most common valve surgery that we do in South Dakota. What would that be, Tom?
Probably aortic valve replacement would probably be the most common one that we do.
And that's more because older people get calcified aortic arteries, or aortic valve.
The valve calcifies with age is the most common one. You can be born with a congenital valve, often a bicuspid instead of a tricuspid, 2-leaflet aortic valve instead of a 3-leaflet. We often see those people in anywhere from day one of birth to 50. I did a 70-year-old with a bicuspid valve last week, and he had made it 70 years with a valve that was well functioning, and so we left it until it finally got stenotic enough that it needed replacement.
Stenotic tightening.
Tightening, yep.
So, and I just see this so much, this calcified aortic valve. I asked the Mayo Clinic doctors one time, what do you do to prevent it? And they said, whoa, lipid-lowering drugs. And then subsequently, all the arteries have come back and said, no, didn't make any difference. But surgery when's the time that you take these people to surgery? That's a good, you combine these guys.
It is. I mean, you get a combination of a couple things. I mean, you get a combination of a cardiologist says, I have a symptomatic patient that has a stenosis by an echo that they look at, and you kind of try to put together and say, how much of this is his aortic valve? And then sometimes we say, well, we also have to do a heart cath. They're old enough they might have coronary disease, and all of a sudden, some of that shortness of breath may be associated with coronary disease, and they may need a valve replacement and bypass at the same time. So it kind of can be a combination of a couple things.
And quite often the symptoms of the tight aortic valve are the same symptoms as what someone would get with coronary disease. So really it's chest pain with exertion, shortness of breath with exertion, or in some cases that are more severe, even passing out with exertion.
Yeah, syncope. So we're talking this valve right here, right? No, that's pulmonary.
Yep.
The red one.
Yeah.
Yep.
And this one over
there
here.
it is, from the left
so
side.
we're looking at, you're not going to get a good view of this, but it's the aortic valve, not these two mitral and tricuspid valves, but the valve that goes up out of the aorta, and the aorta is the major vessel that spreads blood to the brain and the arms and the gut and everything.
Lets blood out of the heart.
So that's an interesting surgery, and it carries with it a certain risk. Like what percentage of people with that surgery
mortality is probably less than a couple percent now in healthy people. The stroke rate's probably 1 or 2%, a little risk of bleeding, a little risk infection. And by and large, it's still the standard of care for aortic valve for people with aortic stenosis.
But there's new surgery.
Yep. Yeah,
transcatheter thing.
Right. They
So
either,
let's just learn about
either
that.
call it TAVI or TAVR, transcatheter aortic valve replacement, or insertion. We really don't replace the valve in the catheter. You're basically taking the catheter, taking the valve and inserting it into the old valve and blowing a balloon up, and with a stent around the valve, it holds right in place where the existing valve is. And so you really are inserting a valve into the hole, where the stenotic valve is, and trying to open it up with valve in it. Right?
So you
exactly.
break open the aortic
You break
valve.
open that calcified valve. You don't sew it in. You hope that nitinol ring will hold it in place. But you know, there've been a couple trials, and it looks to have some promise. But right now, if you can have heart surgery in the old-fashioned way, where you actually stop the heart, remove the valve, sew in a new valve, that's the best option.
Yeah.
Still the best option.
I looked at the data a year ago, and it was certainly riskier to have this trans artery.
Transcatheter.
Well, and I think the main problem is that you can imagine you're talking about a calcified aortic valve that you're trying to blow this balloon and stent that this valve sits on up in there, and you've got all this calcium that you're trying to crush out against the walls of the aorta, and so there are going to be some holes around that blood can flow back into, and so sometimes you trade in having a tight valve for having some leakage around one of these newer catheter inserted valves.
Yeah, my sense is that it's just, maybe we'll get there, but
it's coming. European studies, Germany has probably the biggest registry, and half of them are done through the groin and up backwards through the artery, transarterial, and the other half actually are open, make a little incision in the left chest, and then make an incision here in the heart and slide the valve straight in this way, so you don't have as much risk of stroke by having to go through the aortic arch.
Oh.
And so about half of the valves now are put in transapically at the bottom of the heart, and with a fairly short incision, and you don't have to go all the way up around the aorta, because the stroke rate in the partner trial was about 10 or 11%. So that, which is, if we have a less than 2% with open surgery, you can see that what a devastating complication. That's what probably is. But with the new trials, when we're really looking at aortas now with better CAT scan imaging before we do that, if this is done, their stroke rate's coming down quite a bit. But stroke and probably the leakiness after it's inserted probably are a couple of limitations that are still going to be present.
So we're talking about putting in, with a catheter, putting in a heart valve now, and we're not quite there. But there are some things that we can put in with a catheter. For example, aortic aneurysm, that's just fabulous right now. Tell me a little bit about that.
Well, more and more, since probably 1999, we started doing aneurysm repair. We did either in the belly aneurysm, below the infrarenal, which is called abdominal aortic aneurysms. We now put a covered stent in, has a graft covering the stent, and it basically lines the aneurysm. So it seals below the renal arteries, and then we bring it down to both of the iliac arteries where the aorta divides, and basically line the aortic aneurysm with a new graft on the inside. So sleeve it, like putting a straw through it.
So an aneurysm is dilating, and it's starting to rupture, and it's kind of leaking through the walls, and it's about to blow. And some of these blow, and they die just like this.
Right.
So you're putting in a graft within
inside the aneurysm.
And the aortic is abdominal aorta, so it's coming down, it's spreading to the kidneys.
Most of those right below where the kidney arteries take off is where the aneurysms start. Although we did one in the chest today. So a thoracic aortic aneurysm, same thing. You put the stent up, and it starts right after the subclavian artery, right up here in the chest. So we put the graft right up into the thoracic aorta and line the dilated segment that they had in the thoracic aorta.
So you took off after it was feeding the arteries of the head and the arms.
Exactly. And actually, we do a lot of surgical intervention to allow us to get closer to the arch. We'll do a bypass from the carotid to a subclavian, so we can actually cover up the artery of the arm, so blood goes up the carotid through the bypass to the arm, so we get good purchase on a normal aorta up in the arch before the aneurysm starts. So it's a combination of surgery and endovascular cases it's kind of a double effort. You can't do it all but we can do a combination to make a lot of these cases be done less invasively, and that's what everybody wants. And if you can do it with good outcomes, that's what we think is the best too.
Well, I think we underdiagnose aortic aneurysms. I had one in my office today where I'm looking at this incision from the middle of his chest all the way to his symphysis pubis, all the way across his abdomen, and you had repaired his aortic aneurysm that I had diagnosed 8 years ago or so, and before it blew, because it was about to blow.
Yeah.
Let's talk about diagnosing these and really quickly. We've got just a minute.
Certainly a few of them are found on exam, but usually that's not the case. Usually some sort of imaging has to be done, and at this point, for those over age 65, particularly if they're smokers, probably a one-time ultrasound of the abdomen just to see if there's one that's forming there is probably a pretty good idea.
So ultrasound of the abdomen.
Correct.
In people who are smokers, men in particular who are over 65, I think, is that what it's saying? But it does, you know, if you suspect it or if there's a risk factor, then we need to move in that direction. I have a number of patients who are enjoying life years after having a sudden death experience because they had the good fortune being near someone who could provide cardiopulmonary resuscitation, or CPR. Of course, there are times when people are certainly dying, when CPR would only cause more suffering and when resuscitation should not be done. That, however, is another story for another day. CPR is an emergency effort of chest compression, circulating blood, keeping the body alive, especially to the vulnerable brain, until the heart can be shocked back into a life-sustaining rhythm by a defibrillator. CPR is simply done by placing the heel of one hand on the chest 2 inches up from the bottom of the breastplate, and with the help of the other hand, compressing the chest down 2 inches at a rate of 100 or more beats per minute. 1 and 2 and to the rate of the Bee Gees song, Staying Alive. That's it. Anyone can do it. Recently, we've learned that the most important component of CPR is the chest compression and not the mouth-to-mouth breathing. In fact, studies show compression-only CPR by the lay public has a higher success rate than CPR with mouth-to-mouth. The exception is when halted breathing is the likely problem, such as drowning, drug overdose, or arrests in children. Most of the time, really, sudden death is due to a heart that is not beating at all or is beating way too fast. This, in turn, is due to many reasons, from a blockage of blood flow through coronary arteries, a weakened dilated heart, or even a baseball or hockey puck strike to the middle of the chest. Whatever the reason, 5 to 30% of those who receive CPR will survive, mostly without brain injury, because CPR tides them over until the electrical shock returns a life-sustaining rhythm. The sad news is that more than 50% of those people who could benefit will not have CPR because bystanders or family are afraid they might do something wrong, which is simply not true. The big mistake is not to start CPR. So if you come upon a situation where someone who might benefit from more years of life suddenly stops breathing and there's no pulse, then don't delay. 1 and 2 and staying alive. So we've got a few more minutes to talk about any other topics that you two think we should make sure the public think about. What are issues that we should address? The CPR issue. What's your comment, Jeremy?
Well, certainly I think CPR is probably the most important thing in a collapsed victim that can be done until paramedics get there. Keeping blood flowing to the brain and all the other vital organs. And certainly the second thing after that is once people get there, if there's a defibrillator available, certainly the earlier someone's defibrillated, if they're in a rhythm that requires it, the faster that happens, the more likely they are to survive.
take-home message, Tom?
I totally agree that it's compressions, 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 and that everybody used to be afraid because they said, I don't want to ever touch anybody's mouth, and you don't have to anymore, and that should get people started.
Gentlemen, what a pleasure to have you here. Thank you so much for doing this.
Thank you, Rick.
Well, this brings us to a close of our show on heart attacks. I sincerely thank our studio guests, cardiologist Dr. Jeremy Scott and cardiac surgeon Dr. Tommy Reynolds, both of whom practice at North Central Heart Institute in Sioux Falls, for helping answer all of the wonderful questions about heart attack. Next week, we'll have a special on-call addressing cost-conscious care. Our panel of medical expert will take on your call-ins and your email questions. Please be sure to join us for this very important program, What Can We Do About Costs? The great and insightful Chief Joseph told us, I believe much trouble would be saved if we opened our hearts more. Until next time, stay healthy out there, people.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
LARSON Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by DAKOTA Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.